Dr. Olivier Johannes Boyau will inform us on acidosis in acute kidney injury.
Yeah, thank you, Eric. Okay, good afternoon. Oh my God, metabolic disturbances are so hard, yeah, for afternoon topics. But as I'm a Pacific guy, and as all the previous speakers are my friends, I will use the traditional approach by Anderson Hasselbalch and Stewart to explain the acidosis with acute kidney injury. No war. First, I have some conflict, or not conflict, just links of interest with societies, but not with this topic. No way. You had 15 minutes to explain all the alkalosis in ICU. Unfortunately, I have 15 minutes just for acidosis in acute kidney injury. Thank you for the organizers. And to explain acidosis in acute kidney injury, just we have to know exactly what is acute kidney injury. Just a quick recall: what's kidney function, normal kidney function, and what occurs when kidney dysfunction, and what is acidosis, how I can recognize the specific acute kidney injury acidosis, and which type of acute kidney injury acidosis. We will see all this in 15 minutes, I hope. First, you know that in the kidney you have different parts that is able to do some filtration, some concentration of urine, dilution of urine, electrolyte change, and so on. The disturbances of some of these functions will explain the metabolic acidosis when you face acute kidney injury in ICU. Just to summarize very quickly the different parts there in the glomerulus, you have the filtration. After you have some part of reabsorption of water and bicarbonate, and also excretion of electrolytes in Henle loop. And after in the collecting duct, you can reabsorb also water, bicarbonate, and extract some electrolyte also. And we will see at the cellular level this after. The problem is that you have not just one acute kidney injury in ICU, because you have multiple causes that can cause the acute kidney injury in ICU. And depending on the cause, the reason for acidosis will change. You know that the old definition of acute kidney injury, but it's more simple to explain with this. First, you have the pre-renal acute kidney injury with hypovolemia and hemodynamic disturbances. This is the first phase of sepsis or septic shock, for example. And this will cause some problems in filtration in the glomerulus. But in the same time, because you have not clear difference in all the definition, in the same time you have also direct sepsis and inflammation action on the kidney that will disturb the normal function of the kidney. You have also drug toxicity that you will give to fight against the sepsis. And you have also some part of rhabdomyolysis after surgery, and you have other causes. These causes will have a direct intrarenal effect on the nephron. And this, all the causes can occur in the same time. And it's difficult to know exactly which causes it the first insult. And you have also the obstruction of urinary tract that can cause metabolic acidosis. First, you have seen that with the previous speakers that you have the traditional approach with Anderson-Hasselbalch. You forgot non-volatile buffers and weak acids with this, but you can use the anion gap to try to associate this with the definition, and in that case, try to understand what's happened with metabolic acidosis. You know that anion gap is sodium minus chloride and bicarbonate, and the normal level is 12 or 16 if you take into account the potassium. Thanks to anion gap, we can differentiate normal situation where the anion gap is normal, 10 for example, the hyperchloremic metabolic acidosis where the anion gap remains normal at 10 because it's a mineral metabolic acidosis, and the increase in organic acids or undosed anions that cause an organic metabolic acidosis with an increase of anion gap, thanks to anion gap. But you can also explain this with the Stewart approach. And I know that you are afraid by Stewart approach due to this book, but don't be afraid. We are probably only 50 people in the world to read this book, and 3 of them are in the room, and half of the others committed suicide. If it's too difficult, don't read this book, and go directly to more easier approach to understand just when you have need for explain metabolic disturbances in ICU. The formula are very hard, as Carol explained, but no problem. Just to see that all the parameters that you measure every day in ICU are there, and perhaps more than calculate all days at the bedside. Just keep in mind this picture with all the parameters together also, and it's very easy to understand what's happening when you have electrolyte disturbances to explain metabolic acidosis or alkalosis disturbances. Just cations are positive with alkaline effect, and anions are negative with acid effect. No more. If you have too much positive alkalosis, if you have too much negative acidosis, and never sleep. Okay, it's easy. And now, with the kidney failure, how we can understand what's happening in terms of metabolic acidosis. In the proximal tubule, you have some part of the kidney that is able to reabsorb sodium and bicarbonate, reabsorb sodium there with potassium, with ATP need, and you have also some reabsorption of bicarbonate there and excretion of protons. You understand that if this part doesn't work, you have no reabsorption of bicarbonate, no excretion of protons, and no reabsorption of sodium. Anderson and Stewart are happy because all is explained by the 2 ways. In the other part, the same, but another guy come in the dance with the phosphate. And in this part, if this pump is not efficient, you have no phosphate and protons excretion. And you have a protons accumulation for Anderson and a phosphate accumulation for Stewart. And phosphate is negative, and you have metabolic acidosis due to this. In the collecting duct, the same, you have the phosphate, same explanation, and you have also reabsorption of bicarbonate, but you have also excretion of chloride to be able to reabsorb the bicarbonate. And if this pump doesn't work, you have chloride accumulation, and with Stewart, you have metabolic acidosis, or no reabsorption of bicarbonate, and Anderson is happy also. At the end, in the cortical collecting duct, you have also no excretion of protons if the ATPase pump doesn't work, or no excretion of ammonium ion, and you know that ammonium ion, if not excreted there, go to the liver and is transformed in urea, and accumulation in urea is also a cause of metabolic acidosis. And the same there with bicarbonate and chloride. Everybody is happy. You see that we have all the determinants there for Anderson and for Stewart. In normal situation, as Carol explained, you have this type of situation with equilibrium. But if you have an acute kidney injury, you have seen all the parts that can fail to do the work. And due to this, you have low sodium reabsorption, hyponatremia. You have low chloride excretion, hyperchloremia. You have low phosphate excretion, hyperphosphatemia. And at the end, you have low bicarbonate due to the low bicarbonate reabsorption. Another time, everybody is happy, and you can understand the different ways that you have acidosis with acute kidney injury due to the failure of some part of the nephron. Just to come in the diuretics, to explain the other part, you have the alkalosis, as Louis explained. You know that the alkalosis, the diuretics, will have an action on this pump, the NAKCC pump, and the diuretic is able to block this pump. And if you block this pump, you will no reabsorb 1 sodium, 2 chloride, and 1 potassium. And if you understand Stewart, you know that 2 chloride for 1 sodium, and you are able to reabsorb sodium in other part of the kidney, and it's very difficult for the chloride. And at the end, you will lose chloride, and you will face metabolic alkalosis. It's the inverse of the acidosis. And now to try to understand which part of the kidney fail, and to categorize some acute kidney injury to understand why you have acidosis, you can use also the urinary anion gap. It's quite close to the anion gap, plasma anion gap, but there it's sodium plus potassium minus chloride. And in fact, this is just the reflect of the ammonium excretion, because it's really difficult to measure the real ammonium excretion. And this is just an equation to be able to understand if the ammonium is excreted or not. If the urinary anion gap is very negative, you have a good excretion of ammonium, good excretion of protons, and the kidney is still able to try to fight against the acidosis. If the urinary anion gap is positive, you have a low excretion of ammonium, and you know that the kidney is not able to fight against acidosis. And acidosis is probably due to the kidney directly. To summarize a bit, the acidosis algorithm, when you have some acidosis in the ICU, with a very pragmatic approach, Anderson, Stewart, everybody. You have a high anion gap. This is simple. It's due to organic metabolic acidosis, hyperlactatemia, or ketoacidosis, or advanced uremia, directly due to the kidney, or hypophosphatemia. Simple. Anderson and Stewart are happy. If you have a normal anion gap, it's more difficult. At this part, you have to calculate the urinary anion gap. If the urinary anion gap is positive, and the kidney is not able to correct acidosis by ammonium excretion. In that case, most of the time, it's due to the renal tubular acidosis. You have 4 different types of renal tubular acidosis. Most of them are due to kidney disease already present before the acute kidney injury. And you can see that sometimes congenital, sometimes drug toxicity, the myeloma. This is very rare, you can forget. And you have also hypoaldosteronism, diabetes, and drug toxicity in type 4. This is with chronic kidney disease present before acute kidney injury. And if your urinary anion gap is very negative, the kidney is able to excrete ammonium ion. And the kidneys still have a quite normal function in some part where ammonium is able to be excreted. It's more due to sodium and bicarbonate loss, Stewart and Anderson. And probably it's due to diarrhea and biliary derivation with some part of hypovolemia that can cause this metabolic acidosis. And this could be corrected before you have a definitive failure in the kidney and you have an acidosis due to the kidney failure also. Finally, with acute kidney injury, you have an acidosis. With the traditional approach, is due to the decrease of protons clearance or a decrease in bicarbonate reabsorption. And with Stewart, is due to hyperchloramia, hyponatremia, and hyperphosphatemia. And now, do we have to correct this acidosis? I will let my friend, Samir, to explain this to you. Thank you for your attention.
Thank you, Olivier, for trying to bring peace to Stuart and other lovers. Questions? Yes.
Yes. With the delta anion gap with urinary anion gap and plasma anion? Ah, yeah, okay. No, in fact, I don't use so much anion gap. I use I use the Stewart theory. But more, and I don't use so much the anion gap, the delta anion gap. So I watch the anion gap to see what's happened, and after I use the Stewart theory with the picture to understand which electrolytes go where and what could be the causes of the alkalosis or acidosis with the change in electrolyte concentration. Yeah.
Yes, the problem with the delta anion gap is the same than with the anion gap, because if you have a modification in albumin,
Yeah.
you will have false value, of course.
Yeah, that's the point. All the parameters are not in the anion gap and in the delta anion gap.
Olivier, I have a question,
Yeah.
and maybe Louis could also answer, because I have the notion that the cause of metabolic acidosis during a kidney dysfunction, I don't know, acute or chronic or in the middle, because there is a continuum, is within time, is the move in the cause, because at the beginning it's hyperchloramia, then after hyponatremia, then hyperphosphatemia, and also one unknown or one not very popular cause is some unknown anions which are released during kidney disease.
Yes, but now as I explained, you have, yes, a continuum. And sometimes the first phase of acidosis with some part of acute kidney injury, but you have just small increase in creatinine and urea, but your kidney has still the function of ammonium excretion because it is due to pre-renal acute kidney injury with hypovolemia like diarrhea or biliary, as I explained. And in this case, it's probably more due to effectively hyperchloremia and so on, and you can correct it. And after, in the same continuum, if you have also sepsis aggression and so on, you will lose other, and probably there are also, I didn't talk about this, but there are also other unknown ions that participate to the metabolic acidosis.
I happen to know that Louis Forney measured these unmeasured
Yes.
anions.
Yeah,
So
yeah.
That's why I asked the question.
Sure, because
My friend.
he knows Stewart also.
Yes.
See how sad I am that I spent my time measuring unmeasured anions. Rather embarrassingly, Carol has asked me to speak when I just put a sweet in my mouth. So I do apologise. So we did look at measuring unmeasured anions. There are two schools of thought. There are the school of thought that think I'm completely wrong, and there's the school of thought that thinks I'm right. So the ones that think I'm wrong, I won't name who they are, but the problem was in terms of preparation of samples. Some of these unmeasured anions have a half-life in plasma of about 200 milliseconds. I'll just say that again, 200 milliseconds. So if you don't snap freeze the plasma and store it at -70, you're going to miss it. So if you just store them in the fridge and then measure them a week later, forget it, right? You might as well just measure tap water. So we did measure them, and we found that most of them were Krebs cycle intermediates.
Yeah.
And the thing about Krebs cycle intermediates is, if you remember, that some of them are diacids and some are triacids. So 1 millimole of citrate contributes to 3 millimoles of base deficit. So it's important to bear that in mind. And that doesn't matter whether you're a Stewart's fan or not, because your negative charges still add up to your positive charges. So we found that in the very sick group of patients where you had this gap that you couldn't measure, it seemed to be uncoupled mitochondrial respiration and an accumulation of Krebs cycle intermediates. What that really means, I don't really know, but what we do know is that when ATP sources are low, the other parts of the cell, apart from the mitochondria, generate ATP. And that's called anaplerotic metabolism, if you remember that from your biochemistry. So it may well be that what the cell's doing is tell you it's really stressed. And in fact, if you look back at the unmeasured ones like that are positive in your cohorts, you'll probably find they do really badly.
Yeah, sure. And in the failing kidney, you have part of failing Krebs cycle directly in the kidney, sometimes due to vascular disturbances. And effectively, you have some unmeasured anions that can accumulate due to this.
So thank you very much, Olivier. So